ones joining us for the first time, welcome. This series is developed as a collaboration between the Ajay Drexel Autism Institute and Bancroft, and today Dr. Claire McGrath will be chairing with me this seminar. And Claire, if you want to.
Yep. No, thank you. Just a couple of quick reminders. So Bancroft and Drexel are doing this work together because we really want to support integration of research and clinical care. And we're thrilled with this speaker series and our speaker today. We want to remind everybody, please feel free to put questions in the chat and comments. We'll monitor them and we'll have time for discussion at the end. And we also want to remind everyone that we will be recording this and to please mute your microphones so that we're able to clearly hear the speaker.
So today we have with us Dr. Mary Doherty. She is a consultant anesthetist, clinical associate professor, internationally recognized neurodiversity affirmative, autism expert and advocate, and parent. She is the founder of Autistic Doctors International, a network that now includes more than 1,300 members worldwide, and you can find the link in the chat. Dr. Doherty works focus on identifying and dismantling barriers to healthcare for the autistic community, supporting both autistic clinicians and doctors and the autistic patients, with a mission of improving healthcare outcomes and creating environments that where autistic people can thrive. So I'm happy to give Dr. Doherty the stage. Thank you.
Thanks so much for that lovely introduction and the invitation. It's lovely to be able to talk about this, because it's an absolute passion of mine. But at the same time, some of the data that I'll share is quite tough. It's quite hard to listen to and to take account of. But it's just so important, I think, that we together do try to make things better because the outcomes for our community are just awful in terms of healthcare. So what I like to do is I'm going to give you a mix of kind of personal reflections and some research findings, including how I ended up researching this. I've been looking at barriers to healthcare for autistic people for probably about 8 years or so. And so I'll tell you a little bit about that. And also, as we said, the organization Autistic Doctors International, healthcare for the community is one of our most important topics, really. And to that end, we've developed the Autistic Space Framework, which I'll tell you about. But I also want, and I'm a bit disjointed today because I did a kind of a last minute change of plan in terms of what I'm going to talk to you about, because I do want to include some of my recent data on shame, because shame, as has been described as an affective determinant of health. It's an emotional barrier to healthcare. And I'm reminded of that. My own experience, even in the past week or so. So I was, just to give you an idea of how it operates, I was having some radiology tests done last week. Nothing to worry about, I'm fine, just screening, but still. So I went. No, and even turning up for a screening appointment as an autistic person is tricky enough. Our data shows that half of our respondents, our autistic respondents were only half as likely to attend for screening appointments on schedule compared to our non-autistic respondents. So that's why it's so important that healthcare settings are accessible to us. But anyway, I went into this room, and my initial reaction was to flee as fast as I possibly could. The lights were blinding. The noise was absolutely deafening. And it was a combination of the noise from the X-ray machine and air conditioning. And there was some traffic noise bleeding in through the windows. It was a really old building. So a narrow room with a very high ceiling. So the acoustics were hideous. And I just thought, I cannot do this. I knew the investigation was going to take a little bit of time. I knew there was no way I could tolerate that. And I just wanted to flee. And then suddenly I thought, no, hang on. My work, my passion is advocating for healthcare for autistic people. Why am I reluctant to advocate for myself in this setting? And I really was. And suddenly I realized it was that sense of shame. just the challenge of acknowledging in the moment with the professional peer who knew I was a doctor that I'm autistic. And that means that I'm really struggling in this environment. Um, but I did manage to process it. And I think it was probably the shame of having to admit that I ran as I talked to you today that kept me in the room and made me actually advocate. But I did. I said to the radiographer, I said, look, I'm autistic. That means I'm really struggling with this environment. Can we turn off the air conditioning? Can we turn off the lights? She was lovely, and she did, of course. She struggled to, figure out the controls on the air conditioning. And again, as she was struggling with that, my shame was rising. And the temptation was to say no, it's okay, but actually I didn't. I sat with it, and I let her figure it out. She turned off the air conditioning. She turned off the lights. Obviously, we couldn't turn off the X-ray machine, but that was okay. I could just about tolerate that, but I think it was probably the frequency of the noise on the two different from the two different pieces of machinery that were just interacting in a way that was just intolerable. Um, but in that moment, I realized how important it is that we recognize the impact that shame can have and how it can act as a barrier to healthcare. So yeah, so there is a bit of a content warning around the second half of this talk because I do want to talk about some of the data that I have from a study that I did with autistic psychiatrists, and particularly look at how that interacts with healthcare and accessing healthcare. But before that, let's talk about the autistic space framework, which some of you
And
will be familiar.
Dr. Doherty, I'm so sorry to interrupt, but
Sorry?
there is a little bit of a glitch. We had talked before,
Okay.
maybe if you turned off your video, I wanted
Okay.
to just let you know.
I'll do
Yeah,
that.
please continue.
Okay,
Thank you.
appreciate that. Thank you.
Thank you.
Hopefully that might be a bit better. Um, hopefully it will be. I'm not sure. Usually my connection is fine, but obviously not today. Okay, so that's the Autistic Space Framework, which was developed by myself and two other autistic doctors. Just using our insider perspective, knowing what the learning needs of our colleagues might be, and putting together a framework that was easily memorable. That's applicable right across lots of different settings, as I'll come to in a bit. Now, what have I done? Here we go. Oh, yeah, okay. In trying to turn off the video, I've moved my cursor somewhere. Anyway, so learning outcomes. The goal is for all healthcare providers to become not just autism aware, but autism competent. But also, in a wider sense, for me, the goal is for autistic kids to have the opportunity to grow up confidently autistic. And not steeped in shame, as most of us, particularly those who've been late diagnosed, can tend to be. How can insights from autistic doctors help to make this a reality? That's what I want to talk about today. The Autistic Space Framework, supporting autistic patients, and as I said, shame and healthcare encounters. That's maybe something to take a break from and maybe come back to the recording, for anybody that's feeling a little bit, how do I describe this? It can be incredibly challenging to realize that actually we've been dealing with shame all our lives and not realizing it. It's been termed the master emotion. It is incredibly pervasive, incredibly toxic, but challenging it, recognizing it and being able to challenge it and deal with it is incredibly liberating, which is why I think it's just so important that we do talk about it. And this is particularly relevant for healthcare providers who might be themselves be autistic or otherwise neurodivergent. I often say positionality is everything, and that's really where where the artwork came from. It's the idea of whether you view the world through a neurodivergent lens or not. And the thing is, loads of healthcare providers are actually autistic or otherwise neurodivergent and don't realize. Or don't realize yet, or do realize but can't be open about that, which is a whole other discussion. But the most important thing to recognize about positionality, particularly anybody involved in diagnostic services, is that the data from my study with autistic psychiatrists shows that psychiatrists, and this would equally apply to other diagnosticians who do not recognize that they are autistic, risk missing the diagnosis in autistic patients. So it's just really important to recognize just whether or not you might be neurodivergent. So looking at Autistic Doctors International, we are a group of autistic doctors. There's over 1,500 of us at this stage. It's just growing by the day. It's just phenomenal. I started the group in 2019 with less than 10 members. And as I said, we now have 1,500 worldwide. That's our leadership team, all senior, successful autistic clinicians, openly autistic, and across a range of specialties. That's our link tree. We recognized really early on that the only way to really make change in medicine was, publishing in peer-reviewed literature. So that's what we've focused on. And there's lots of our work there. And then I turned this into a PhD for myself, which I just published earlier this year. Just finished that earlier this year, looking at barriers to healthcare, the autistic space framework, and my initial paper on the autistic psychiatrist project. But there's lots of other things that we've published. There's one in medical education about the neurodiversity paradigm, which is a really good place to start for anybody who's a little bit confused about, the concepts or the terminology. And then the other one that we've done recently published, we've adapted the autistic space to education. And we published it in a neurodiversity journal, and that was a project led by some autistic teachers. So any for parents that might be particularly useful, or anybody involved in education. It's also been adapted to social work. And in case I get distracted, which I often do, it's useful to pop these up at the beginning. Just the fact that autism is so much more common than is generally recognized, and we can absolutely thrive. The idea that we have to be, it's the idea that, particularly for doctors, that if you're autistic, the sense is that, well, you have to, you're going to be in difficulty. That's not the case at all. We absolutely can thrive. And the thing is, most of our members in Autistic Doctors International, the majority don't disclose, particularly those who are successful and don't have to disclose. So there is this unfortunate association between being autistic in medicine and being in difficulty, but it's not true. We have to actively challenge that. Understanding is the primary need. Negative framing perpetuates shame and stigma, and I have no doubt that impacts on our mental health negatively, and that reframing our view of autism, moving towards a neurodiversity affirmative approach, will absolutely save lives and careers. For patients, autistic patients turn up in all sorts of healthcare settings. People tend to think it's just in psychiatry or in pediatrics. Absolutely not. Autistic people are accessing every healthcare setting imaginable, but we're a hidden minority amongst patients, and our outcomes are awful. Why would we have reduced mortality? Why would we die earlier from, conditions such as, cancer or heart disease, but we do. Life expectancy is reduced. Lots of conditions are more common, but simple adjustments can facilitate access to healthcare. And then for families, we need to start recognizing that autism runs in families. Lots of parents, not even start recognizing, but start acknowledging and start talking about the fact that lots of parents are also autistic, whether they realize it or not. And the thing is, autistic and neurodivergent family dynamics are really different to neurotypical expectations, and we need to support families in that. And the thing is, healthcare trauma is very common, and again, that acts as a barrier to future healthcare. So this is where it all started for me. These are my two munchkins. And the little one was initially identified, at which point that started the journey for us all, recognizing that this is what, unites us all. And it has been so incredibly validating and liberating to realize that we're all perfectly good autistic people. We're not failed neurotypical people. And, again, the mental health implications are really, really profound. So I have no doubt that a neurodiversity affirmative approach is the way to optimum outcome. This is the space framework again. And the thing about it is, when we started to develop this, it was after we had completed our barriers to healthcare projects, which I'll talk about in a moment. And we wanted a solution that was easily memorable, and that particularly built on what's really common in medicine, which is the value of a good mnemonic, good graphics and a good mnemonic. Anything like that with, with a good graphic and good mnemonics is just easy, it's just much more accessible. Most of us will know the Bristol stool chart, probably the most successful, apart from the Glasgow Coma Scale. This is actually what was my initial inspiration, because the thing was, the Glasgow Coma Scale was developed in the 70s. It is internationally known. It's the first thing everybody in the world thinks of. Anytime there's a loss of consciousness, head injury, the first question is, what's the GCS? And the thing was, prior to the development, clinicians and researchers didn't have a common language. So outcomes were dramatically improved after the development and the implementation of the Glasgow Coma Scale internationally. And that's what I hope that we can do with the Autistic Space Framework. And the thing is, it's a descriptive acronym. It gives you the main message in the title, because usually what we need is a little bit of extra space. But specifically what it stands for is what we see as the core needs of any autistic person in any setting, really. That's sensory needs, predictability, acceptance, communication, empathy, and the three further domains: physical space, processing space, and emotional space. We developed it during COVID, so PPE was a useful acronym for that. This is where you'll find it. We published it in the British Journal of Hospital Medicine. And it's been really, really well received. It's in use internationally I've lost count of the number of counties and settings that it's in use at the moment, and use is growing daily. I'm regularly receiving emails or requests to collaborate on projects, or finding, even just hearing on the grapevine that various services are using it. And what I can tell you is that everywhere that uses it loves it, because it really helps. It really does make a difference. We'll be at INSAR in April with some data from a disability service in Ireland, the biggest disability service in Ireland, where they have adopted it right across all of their services, and they're finding it really useful, particularly in what might be termed high risk, high support settings. So that's particularly interesting. So we'll have some data on that hopefully soon. Briefly, to talk about the barriers to healthcare projects. I won't get into it in detail, but the papers, this is where I started. And where this project started was I was asked to develop some healthcare provider training back in about 2018. And my initial response was, okay, what do the community say that doctors need to know? And that's how I originally, started to investigate this, and that has then turned into this project, where we first published the quantitative findings in the BMJ Open, and then we published the qualitative paper in Autism a little while later. And the key findings really was that, the barriers that we found were very similar to what had been found by other teams, but we found an association between those barriers and self-reported adverse health outcomes. Prior negative experience has been shown to be an independent barrier to future care. 80% of our autistic respondents said that they had difficulty accessing a GP when they needed to go. So it wasn't just in general, it was when a visit was needed. The vast majority said that they avoided using the telephone, and that was the biggest barrier to accessing healthcare. And that was a much bigger issue back 8 years ago. We've moved a lot more towards, digital access to healthcare, which is really beneficial for autistic people. But the telephone is still an enormous barrier. Over half the group said that they avoided or delayed a GP visit because they didn't feel understood. And for doctors on the group, just think about our patients not coming when for care when they need it, and like the consequences are huge. Mental health conditions, 70% almost of the group said that they didn't access healthcare for a mental health condition. Almost the same for physical conditions. A third of the autistic group said that they didn't access healthcare for a potentially serious or life-threatening condition. So it's no wonder. You can see how that potentially feeds into our mortality, our premature mortality figures. people described late presentations, emergency admissions, needing more extensive treatment or surgery than if they had presented earlier. Interestingly, we found no difference between self-identified or formally diagnosed autistic people. And also we found that many autistic adults had no access to primary care at all. What we then did was we looked at the healthcare journey. This was from the qualitative findings. And we looked at the pathway from those early barriers, sensory challenges, interoceptive differences, not knowing when a GP visit was needed even, communication difficulties, the doctor-patient relationship, diagnostic overshadowing. You know, the idea that every new symptom is put down to a known diagnosis. You know, often, autism, you know, you're anxious. Well, you know, you're autistic, you'd expect that. No, absolutely not. That is not true. You know, and sometimes it even gets as far as like you go with a knee pain. It's like, well, you're autistic, you'd expect that. Absolutely not. Diagnostic overshadowing is just so prevalent for our community. But that sense of just not being able to access healthcare, what we termed then learned helplessness and fearing repercussion, leading into healthcare avoidance. What I now recognize is that is shame. After I had the data on shame in terms of the Autistic Psychiatrist Project, I went back and I looked at the data, the qualitative data from our Barriers to Healthcare project. And gosh, shame is right there through the entire data set. We just didn't recognize it enough to name it at the time. But looking back, you know, that's what it is. So that healthcare avoidance, a lot of that is shame-based, and that has serious consequences in terms of adverse health outcomes. So it's really important, I think, that we talk about this. But before we do, let's briefly look at the SPACE framework again in a little bit more detail. I'm not going to go through it all, but I just have a couple of photographs that I wanted to show you, particularly around sensory issues. Because if you're not autistic, you're not going to recognize that the way we experience the world is genuinely different to how non-autistic people might do. So this was a chat that I was having with an orthopedic surgeon colleague a while back. We were outside one of the operating theatres, and he was asking me just, you know, what it was like to be autistic. And I said, for example, I'm struggling to focus on our chat because of the noise from the air handling unit above our heads. I have to actively focus, whereas you might just filter it out. And he just went, what noise? And the thing was, I took that photo with the noise app on my phone, and it measured 75 decibels. That was after he'd gone, so there was no voices there. That was just the background noise that I was constantly battling throughout the entire day to tune out. Well, I can't tune it out, but to get past it. Whereas he just tuned it out. You know, in the same way, if you live beside an airport, you don't hear the planes anymore. That doesn't happen in the same way for autistic people. We do not habituate in the same way. And another one that I like to use is from the, you know, just looking at light. I'm really light sensitive. Now, I didn't take this photo, but when I saw it, and particularly when I saw this one, I recognized this. I know what that feels like. You know, I'm not saying it's sort of that my visual processing is distorted to the point where I don't see things, but it was like I recognize that in the same way that you might recognize a caricature, if that makes sense. And just think about what it's like, what it might be like to be sick or in pain, in mental distress, in an emergency room, when you're needing health care, but you're also experiencing the environment as that photograph shows. Just how much harder it is and how much of a difference it could make to just be able to wait somewhere else, to be able to wait in a quiet room, to be able to turn off a light, to be able to wait outside in a car. You know, simple adjustments make a massive difference. And in terms of time, I won't get into this one, but this was one that I wrote about, actually. It was a sensory overload experience that I had myself, where I literally lost access to fluent speech. And, you know, as a doctor, maybe publishing in the Lancet is kind of, you know, maybe the holy grail, and maybe not for something like this. But, you know, I'm lucky enough to have the platform that I do, and I was able to, you know, challenge the shame involved. But even in terms of the shame that I experienced around this, it took me probably 2.5, 3 years after the episode in question for me to be able to write about it and to be able to share about it. But anyway, you can read about it there. The QR code is there. the core of our framework, the core of my work is all around acceptance. It's the idea that, sorry, wrong one, press the wrong one. Did I press the wrong one? No, here we go. Yeah, I meant to talk about predictability first, but because that's the second part of the framework, predictability, just how important it is to maximize predictability, because healthcare is inherently unpredictable. It's unpredictable outcomes, unpredictable people, unpredictable environment. So anything that you can do to maximize predictability really helps. But back to acceptance. The core of the framework, the core of all my work, a neurodiversity affirmative approach is absolutely the way to optimum outcomes for all autistic people. Better mental health outcomes, better career outcomes as well in terms of supporting our colleagues. And one thing that's interesting now that I'm working on shame is that this was a slide that I wrote, excuse me, several years ago. And I didn't realize just how important the one thing that I wrote, which was avoid shaming for autistic behavior. It is enormous. It happens all the time, all day, every day. Autistic kids are being shamed in school for being autistic. Autistic doctors is same in workplace settings. The message that we get from the time that we're tiny is that somehow we're wrong, we're disordered, we're broken, we're defective, because we do not meet the neuronormative expectations of a majority neurotypical society. And the implications for autistic people, particularly in terms of mental health, is just enormous. We really have to start talking about this. Also, just a bit of data on that one. To move on, if I can. Yeah, so we have a bit of data from autistic doctors. This was a membership survey that we did a few years ago. Look at the specialty breakdowns. That's not what people tend to expect. GPs or family physicians, I think, across the pond. But psychiatrists is the most overrepresented group, the second largest group, but the most overrepresented. But what's interesting is that less than a third had disclosed to their colleagues. And again, thinking about the reasons for that, we looked at mental health. We looked at how people framed autism, whether they viewed it as, difference, disability, disorder. Most preferred the term autistic doctors, not person first language. But also we looked at the mental health outcomes in terms of suicidality. So 3/4 of the group had experienced prior suicide attempts. Sorry, suicidal ideation. 1/4 had at least one prior suicide attempt, and half had experienced self-harm. And the associations were interesting. Considering autism to be a disorder was associated with a preference for person first language for doctors with autism. But really interesting was that considering autism to be a disorder was associated with having attempted suicide. And I think there's lots of ways you could interpret that, but I think looking at it in terms of the disorder deficit framing of autism, that core deficit framing, versus a neurodiversity affirmative approach, it's not hard to see how it's possible that if you grow up with that sense that you are broken, defective, disordered, that might lead to negative mental health and negative outcomes. This is an illustration by James Henderson, who does our artwork, just of the concept of masking. That idea of having to hide the essence of who you are and having to present to the world a caricature of who you are, and hide the essence of your identity. I think it's so important that we understand not just the effort that takes, because it's exhausting. It's like working, for any of you who have for example, if English is not your first language or you've worked in a different country. I spent a year working in France, when I was not fluent in French, and it was absolutely exhausting. And that's what it's like masking. That's what it's like, communicating as an autistic person in a majority neurotypical world. But I think more important than that is what it does to our identity, to our very souls, to have to, present a self that is not authentic, because the message is that our authentic selves are unacceptable. And I think we have to challenge that. So where this comes from is the Autistic Psychiatrist project that I published the first paper from last year. Now, this one was looking at how autistic psychiatrists came to recognize themselves as autistic, how they then came to recognize that loads of their colleagues were autistic, and also then how they, as I said at the beginning, that if they didn't, or before they recognized that they were autistic themselves, they missed their the diagnosis in patients. But then the next part of the analysis, haven't published that yet, it's in preparation. But it was looking at the reasons for seeking a formal diagnosis or not, and disclosing or not. And I've talked about this elsewhere, so I'm not going to get into the data, but I will say that the overarching theme for why autistic psychiatrists didn't disclose was shame. Really, really tricky data to deal with, tricky data to share. But I think, again, going back to what it does to us internally, I think it's really important that we do address this. And then I engaged with Professor Luna Dolezal's work with the Shame and Medicine project. So anybody who's interested in this area, I would direct you to the Shame and Medicine project. It's just fabulous. It's been running for several years, and it's looking nothing to do with autism, but looking at the impact of shame in healthcare. And that's where the idea, they raised the idea of shame as an affective determinant of health. And also what's really a really nice paper is that one down at the bottom there, where they're looking at where the title is Beyond a Trauma-Informed Approach and Towards Shame-Sensitive Practice. Because they're making the point that while the appreciation of trauma is growing exponentially, and people are conscious of, using trauma-informed approaches, without recognizing the role of shame in trauma, that's maybe incomplete. So they advocate for shame-sensitive practice, shame competence, which is just so important. This was the project that I presented at the American Psychiatric Association annual meeting last year on the project, and just some of the quotes just really highlight the message that we get from when we're tiny, just that we're wrong, we're broken, we're, just odd, just something wrong. And that is what we absolutely have to challenge for the next generation of autistic kids, because we can't let them, grow up steeped in shame and continue to have such awful outcomes. Shame's the master emotion. It is deeply, deeply painful. And the thing is, it's different to guilt, which a lot of people don't recognize. Guilt is I did something bad. Shame is I am bad. It's the self as defective. Deeply painful. Shame avoidance and chronic shame anxiety is linked to depression, substance misuse, violence. So many negative outcomes, and the underlying shame is often not recognized. So I talked about this a little bit in a blog that I did for the Shame and Medicine project. That's available online. I'm talking about, we're trading shame so much in so many of our encounters, and indeed in healthcare encounters. But even if you look at what we term the autism wars, between autistic parents, autistic advocates, shame is underlying that. So much of the debates in research, in autism research, looking at that through a shame lens can look very, very different. And then in terms of healthcare, so I have a paper in review at the moment where I'm talking about autistic shame, reflections on an under-recognized determinant of mental health. We are regularly shamed in healthcare settings because we don't present as the good patient, the expected patient. And then we often have non-specific, vague physical conditions that are often associated with autism. Gaslighting, we're not believed, we're assumed to be malingering or fabricating illness. And then, as I said earlier, healthcare avoidance due to prior failure to access healthcare. It is real, and it has really negative consequences for us. And then, of course, we avoid healthcare and present later with more serious illness. And again, we're often shamed for that. Why didn't you come? Why didn't you come earlier? The ways to address this is to recognize the implications, I think, Shame dies when spoken about in safe places. I love that quote. But also Brene Brown's work is interesting. What she said is, for shame to grow exponentially, it needs secrecy, silence, and judgment, which are things that, as autistic people, we deal with, on a daily basis. But also, she says, when it comes to shame, understanding it is a prerequisite for change. So even though this is really difficult to talk about, I think it's just so important. Often I've talked about this, and people have said to me that recognizing that shame has been the underlying current of their life has been life changing. So for people, with the courage to confront this, I think it is so important. And the difficulty is, it often doesn't get addressed, even in therapy. Not overtly. And commonly therapists know about it and recognize it, but don't specifically, deliberately don't talk about it. But I don't think that's a good approach with autistic people, because we're not known for sort of reading between the lines. But also in terms of service improvement, it's known that a recurrent challenge to improving service, any service provision, progress in any field, it's related to shame, because the difficulty is that recognizing a need for improvement by necessity implies that previous practice was less than ideal. And I think particularly maybe for us in the autism field, for clinicians and researchers who've devoted their lives to helping autistic people, it's enormously challenging on a personal level to acknowledge that past work may have done some harm as well as having brought benefit. And that the challenge of switching from that core deficit paradigm to a neurodiversity paradigm, and more people are doing that. And as more and more people do, more colleagues, join along. When people realize the benefit for themselves, their families, their patients, but without recognizing the impact of shame, it might be harder to actually make that switch. So again, it's another reason to address it. Luna Dalzell has a fabulous paper on shame competence, and the factors would be maintaining an awareness of shame, recognizing shame when it happens, avoid inducing shame, providing proactive support when it happens, and then transformation at an organizational level. I want to adapt this to what I'm terming shame competent or shame sensitive parenting, because I think so much of the traditional parenting, and especially when it comes to autistic kids, runs the risk of inducing that sense of shame. And again, not being able to be openly autistic. This is one of my participants, from a psychiatrist, looking at the big picture. Probably the fastest way to achieve change would be if everyone was to stand up and be like, "Hi, count me in, you're a divergent here." Suddenly it would be apparent how many of us there are. And that is so true in healthcare and in autism research. But, and this is very valid, I don't think it would be a right thing, to suddenly ask everyone to do it, because it is such a gamble, and it really is. The consequences for, being openly autistic for many of our colleagues are career changing, career ending sometimes. So it is really serious, that really important that we change the culture in healthcare and indeed in autism research, where it's safe to be openly autistic. Some of our students, though, are really leading the way on this. This was a student project that is currently actually either under revisions or in production. I'm not quite sure yet. But I love this quote. Participants didn't disclose their autism diagnosis. This was about medical students, for fear of consequences from peers and staff. These negative associations promoted a sense of shame. Culture of silence about being autistic was embedded in their experience. It's almost like if you have it, it's a dirty secret and you don't let people know. Some of the other students, though, are challenging that. Here's a quote I love. "If you behave as though you're ashamed of something, then you send the message that it's something to be ashamed of. And for other autistic people, it's important for me to not act as though I'm ashamed of it." Healing happens through self-compassion, because there isn't nothing shameful about being autistic. And that's the most important thing for all of our community to understand. There's nothing shameful about being autistic. Yeah, we experience the world in a different way. We're not disordered or defective. Autistic shame, it is not inevitable. It's not immutable. It's external, it's imposed, and it's learned. And we have to challenge it. We have to. And the thing is, there's not a lot we can do. This, how stigma in society, we recognize stigma. We talk about stigma in the community a lot, but we don't acknowledge how stigma is embodied, how it is experienced on a personal level, and that is as shame. But there's not a lot we can do about societal stigma, but there is a lot we can do about our own shame. And we can do that by helping others to work through that shame. And by doing that collectively, we will absolutely challenge the social forces that perpetuate it. I'm going to leave it at that, I think. That is the framework again. I won't go through the others in view of time, but only just to say, if you're in healthcare, can you implement this in your practice? Can you find a way? We have so many settings that are using it, but what we really need to do is build the evidence base for this. So if you do use it, please evaluate it, because I think this is a way to really help better outcomes for our community. Autistic kids need that opportunity to grow up confidently autistic. And not quite done, but nearly done. Just a final reflection. This was from one of our leadership team in ADI, consultant psychiatrist, forensic CAMS consultant, Anna Rabowska, where she says, what do we do into the next generation if all the successful autistic people are in hiding? You know, and again, we link that into the sense of shame. I think it's just, and consider the mental health outcomes for autistic people. I spoke at an event in the UK Parliament a couple of weeks ago about autistic girls lost to suicide. You know, I spoke alongside two mothers who'd lost their autistic girls. You know, and it's just heartbreaking. And it's, you know, we can change that. We can make things better for the next generation. And just one thing before I finish is that we have a book coming out soon on navigating healthcare for autistic people. That's written with 3 autistic GPs. Hopefully will be out by the end of the year. And now I am done. I'll leave it at that. So that's my contact details.
Thank you
Please
so
do